Now, the changes that take place within the cardiovascular system as a consequence of this leak that is imposed upon the heart are an interplay between numerous different systems. And those numerous systems which lead to the adaptation begin initially with a nervous adaptation, typically the adaptation within the autonomic nervous system. But that leads on subsequently to an endocrine response where there are, again, multiple endocrine systems that are at play. And eventually the neural response and the endocrine response is followed by a hypertrophic response or a remodeling of the heart, where the heart undergoes structural change as a consequence of the disease process. Now, it's easy to think of these processes as being sequential, with the nervous changes first and then the endocrine changes and then the structural changes, but actually, realistically, it's more likely that there is an interplay with all of these processes occurring at once. It may well be that the nervous changes are the ones that are first recognized, and also the nervous changes are the ones that happen more rapidly, but the endocrine changes and the structural changes effectively occur alongside, and all three systems together contribute to the disease process. Now, if we focus initially on the endocrine systems in heart failure, there are three main systems which I'll talk about. One of them is the renin-angiotensin-aldosterone system, and that has a very key part to play. I'll also mention something about the ADH or arginine vasopressin system, and say a bit about natriuretic peptides too. But the renin-angiotensin-aldosterone system, and in fact any of the endocrine systems, and this is something of a theme which I'll come back to in a moment. Initially, what happens is they are stimulated in an effort to try to adapt to the disease process, and many of their initial functions may be favorable. It may be that they help the body to adapt. However, when chronically stimulated, those systems may end up having a detrimental effect. So there's this balance, and it's probably oversimplistic to view the certain endocrine systems in heart failure as being bad and other ones as being good. It's actually a balance even within systems for them having some aspects of their function which have a favorable effect and other aspects of their function which are unfavorable. Now, with respect to the renin-angiotensin-aldosterone system, in heart failure, when that system is stimulated, if we think about what effects the products of that system have, the two main endocrine products of that system are angiotensin II and aldosterone. Now, angiotensin II is a hormone that leads to vasoconstriction. So the blood vessels constrict as a consequence of its function, and what that does is it protects blood pressure. So in animals who have some sort of heart disease, constriction of the vessels puts up blood pressure and helps the animal initially to adapt. However, chronically, that stimulus, that chronic vasoconstriction, can actually contribute to the overwork of the heart and worsen the situation. Paradoxically, in valvular heart disease, particularly mitral valve disease, if you're vasoconstricted, you actually worsen the leak in the valve because there's a greater tendency for blood to leak back. The other hormone which is involved in which is a product of the renin-angiotensin-aldosterone system is aldosterone itself. And aldosterone has a role, initially, its main role is as a volume regulatory hormone. So aldosterone leads to the retention of sodium in the nephron. That retention of sodium also leads to retention of water, and that expands the circulating fluid volume. And that expansion of the circulating fluid volume initially may have a favorable effect because it can improve the function of the heart through a mechanism called the Starling reflex. But chronically, if that system is activated, then aldosterone can have detrimental effects, either through simply continued retention of sodium and fluid, leading to the state of congestion late in heart disease, or through other effects of both angiotensin and aldosterone. Both of those hormones, as well as having the effects which I've already outlined, have effects upon the heart muscle itself. So they are thought to be some of the contributory factors which eventually lead to remodeling and hypertrophy within the heart. So they start out having the favorable effect that they are desired to have, but ultimately may contribute to the deterioration in heart function that precipitates heart failure in the late stages of the disease process. I'll briefly say something about antidiuretic hormone, although it's not necessarily such a key player. Antidiuretic hormone is another volume regulatory hormone. What it does is, rather than leading to retention of sodium like aldosterone does, antidiuretic hormone leads to retention of water. And in doing so, again, it expands the circulating fluid volume. However, because sodium has not been retained, you retain water in excess of sodium, having the net effect of diluting the sodium within the circulation. So one of the visible effects, of late stages of heart failure, is a drop in the sodium concentration in the blood, and that's brought about probably through ADH effect, what's called non-osmotic release of ADH. But that's not believed to be quite such a key player in the remodeling effects, which are some of the things which I'm going to outline.